everyone, and all of you who've been such faithful attendees to these presentations that we've been having the last couple of years. We so appreciate that, and you honor us by attending and the comments we get, and when we run into you in the hall. Thank you so much. As you know, the teaching effort that's a part of our clinical service here at Butterfield Trail is the education of resident physicians. These are physicians who have their medical degree, and it's the first 3 postgraduate years after getting their MD or DO degrees. And so at any one time, for 4 weeks at a time, we have 2 residents here. This afternoon, we just have one of those 2 residents because the other had volunteered to be doing COVID testing on at another place, administering those, and so we gave him a free pass. But I'm pleased you're attending this afternoon. I think this is going to be a very worthwhile talk, and we'll probably clear up some questions you might have had about colon problems. We initially thought we would do this on diverticulosis, but really we've changed it into a little bit broader presentation of common disorders of the colon in older adults. So I think it will be helpful to you. I want to, at the outset, remind you that you can submit questions by calling our on-call number, the very same one that we use for calls should you're having problems after hours. It's the one that the resident physician has 24/7. And that number is 479-200-9259. But if you call that during the presentation or at the end, we'll take the question and give it to Dr. Williams, and she and I will attempt to answer it. So let me introduce our speaker today. Dr. Kayla Williams is a second-year resident, so she's in the second of her 3 years of training in internal medicine with us. She has distinguished herself in the time she's been here, witnessed by the fact that she just last week was named one of our chief residents for next year. So in her 3rd year, we always have 2, and now we've determined we're better served by having 3 chief residents who are cited by their peers, their colleagues, the other residents, and then approved or chosen by the faculty for special duties over the residency. And so she's one of our 3 for next year, and that's a great honor. She's not from Arkansas, as so many of our trainees are. We have trainees from all over the country, but Kayla Williams is from Kentucky. Now, that's eastern Kentucky, so she says sometimes the Ozarks remind her of the Appalachians and where she grew up. But she's a graduate of both the University of Kentucky undergrad and the University of Kentucky Medical School. And Kentucky must be very proud. She is an outstanding young physician. So with that as an introduction, and by the way, she's outstanding in so many ways. You would also recognize that anyone who could do what she's done and what we ask them to do, these, as you can imagine, are not the least stressful years of one's life, and have 2 babies along the way. So she has a 3-year-old who she gave birth to in her 3rd year of medical school, and then since she's been in Northwest Arkansas, she's had another child who's 1 year old. So she was a first year. She was an intern when she had that baby. So, none of us guys know how to relate to this because none of us would have been up to that, I'm pretty sure. So without further ado, I'll introduce Dr. Kayla Williams.
Okay. Well, now that he's built me up so much, I got a high bar to live up to. So, like I said, I'm Kayla Williams. Today we're going to talk a little bit about some of the more common diseases that we see in the colon. And in order to do that, I just want to start out talking about the digestive system anatomy so we can kind of follow along with these diseases a little more easily. So we start at the mouth, and then when we swallow our food, it goes down the esophagus into the stomach. And just below the stomach, the liver and pancreas help digest the food. And then from that point on, you're in the small intestine. The small intestine is broken down into 3 different parts. The top part is called the duodenum. The middle part is called the jejunum. And the most important one for our talk today is the last part of it called the ileum. And then from that point, we go on to the colon, and where the ileum and colon meet, we have the appendix, which most people know about. The colon itself is divided into separate portions as well. So you've got the portion that goes up the right side, that's called the ascending colon. And then it crosses over to the left side, that's called the transverse colon. And then it goes back down toward the legs, that's the descending colon. And then it makes a little S shape. That portion's called the sigmoid colon, and then on to the rectum and anus. Okay, so the first disorder I want to talk about is probably the most common of all of them. It's diverticulosis. That's just a fancy name for having some pouches in the wall of your colon. It's a really common disorder. Up to 45% of people in our country have these little pockets in their colon. The incidence actually increases with age. So about 20% of 40-year-olds have them, and then by the time you're 60 years old, you're looking at roughly 60% of people have them. In the Western world, they're most frequently found on the left side of the colon, but in the Asian population, it's actually more common to see them on the right side, just from some genetic variations. Symptoms, you're typically asymptomatic and have no idea that you even have these. So if you end up developing symptoms, it's usually from the complications that can occur, like bleeding and infection. So let's talk a little bit about those complications. And we'll start with the bleeding. So this left picture that we're looking at just shows the anatomy of those little pouches, and you can see that there's no real muscle in the wall of those pouches, and the skin is very thin. The lining of the colon is very thin, and so that leaves the blood vessels pretty close to the surface, and they can get scratched up and bleed pretty easily. Between 5 and 15% of cases of diverticulosis end up resulting in some bleeding. 50 to 90% of those cases are actually on the right side, and we're not really sure why that is. But it is overall the most common source of lower GI bleeding, responsible for up to 40% of the bleeds that we see from the colon. 80% of these cases end up self-resolving, and we don't really have to do much about them, but you can have some life-threatening complications in about 3% of the cases. Sometimes the bleeding can require hospitalization, and that will lead to some interventions like fluids, blood transfusions. And then if the bleeding doesn't stop, they can go in and do a colonoscopy, and that's the picture you see on the right there, what it might look like. So you see the pouch and some blood flowing from it. And kind of like this picture, most of the time the bleeding is minor. You don't see a ton of blood in there, but occasionally it gets much worse. It's particularly bad in the elder population just because they have so many other health conditions that can be complicated by the bleeding. So that's particularly of concern for us. Symptoms include obviously some bright red or maroon blood in your stools, belly pain, dizziness, lightheadedness, low blood pressure, high heart rate, and shortness of breath. And all those last ones typically show up if you've bled enough to have low blood counts. And then our next complication is infection. The name for this is diverticulitis. You may have heard of it. It's fairly common. And that's just when infection sets up in the pouch. It can range from mild cases that just need antibiotics to some pretty complicated situations that we'll talk about a little more in depth in a second. You can see what the colonoscopy looks like on the right again, and I apologize, these pictures can be a little gross, but it really helps to discern the difference between all these disorders just to see pictures of them. And so you can see the pockets that are the diverticuli, and in that far right picture you can see some pus that's set up in one of them and some drainage. So diverticulitis, we're more concerned about the severe cases that end up having complications, and some of those complications can be an abscess, which is a walled off pocket of infection. It's really hard to get antibiotics into those abscesses, so most of the time they require surgical drainage of the infection inside of them. Perforation or rupture of the wall of the colon is another big concern, as well as peritonitis or just generalized abdominal infection. Both of those require emergency surgery just to clean out the infection and possibly end up taking out the disease portion of the colon. That's a pretty big surgery, can require multiple steps over the course of several months. And occasionally, surgery is done electively, particularly in people that have recurrent infections, or if they just have bad immune systems that would prevent them from fighting off infections in the future. And then after all these complications have been treated and you get out of the hospital, you'll have a colonoscopy done a few months later to try to assess how extensive the disease is in your colon and decide if you do need that elective surgery to remove portions of it. 85% of cases of diverticulitis actually do not have complications and just respond to basic antibiotics and supportive care. And then roughly 15% of the others require surgery from complications. 30% of patients that have an episode of diverticulitis will go on to have a second episode, and then the other 70% will likely just be asymptomatic for the rest of their life. And if you end up having a repeat episode of it, your symptoms are likely to be pretty similar. It was previously thought that each episode might escalate, but that's turning out to not be the case. General symptoms from mild or severe cases initially are just belly pain, particularly in the left lower side where most of those pouches typically occur. Nausea, vomiting, fevers, and the severe cases will require hospitalization, but the mild cases are often just treated at home with antibiotics and a few days of a liquid diet. Okay. So we'll move on to, that didn't go, did it? There we go. We'll move on to a category of colon diseases called inflammatory bowel diseases, not to be confused with irritable bowel syndrome, which is quite a bit more common than these. These are autoimmune diseases where the immune system attacks your own body. And the most common ones that we see are Crohn's disease and ulcerative colitis, and we'll dive in depth with each of these in a second. So this category of diseases overall typically occurs in between the ages of 15 and 30, but there's also thought to be a second peak between the ages of 50 and 80, so it is still pertinent to the geriatric population. Technically, these can show up at any time. This is just the typical trend we see. They are more common in Caucasian and Jewish populations. And we will start off talking about Crohn's disease. So our little graphic here shows that Crohn's can actually affect any part of the colon or the small intestines. The most common place is at the very end of the small intestine into the colon, where I said they met up and the appendix was located. At the junction of the colon and the ileum, but like I said, it can affect any part of the intestines. 30% of cases are solely small bowel, 20% are solely colon, and then the rest of them, the other 50%, are some mixed portion of the intestines. Symptoms, crampy abdominal pain, particularly in the right lower side because that's where the colon meets the ileum. They'll have diarrhea, fatigue, weight loss, sometimes fevers, and vitamin deficiencies are fairly common just because the inflammation of the intestines can prevent good absorption of your food and your vitamins. Some people will also have symptoms outside of the digestive tract. Eyes and joints, arthritis type symptoms are pretty common in these diseases, both Crohn's and ulcerative colitis. Crohn's patients can also develop complications similar to the diverticulitis, so they can get abscesses that require the treatment we talked about already. They can get something called fistulas, which is just a connection between the intestine and surrounding structures like the bladder or the back muscles. And then they can also get strictures or narrowing of the intestine that can lead to obstructions. Pretty much all of these will require surgery at some point. So diagnosis of Crohn's disease is by colonoscopy and biopsy, and I've got another lovely picture for you there showing the inflammation that you'll see with Crohn's disease. It can be pretty severe. Treatment for it, besides the surgery for the complications we just talked about, it's pretty commonplace to use steroids or other medications that suppress or change the immune system to keep it from attacking you. Now, there's a lot of overlap between Crohn's disease and ulcerative colitis, so I won't go back through all of it. I'll just talk about the ways to differentiate the two. Like we talked about, Crohn's affects the colon and the small intestine typically, while ulcerative colitis is strictly the colon. And typically it affects the end of the colon from the descending to that S-shaped sigmoid down into the rectum, whereas Crohn's typically affects the closer end of the colon up toward the small intestine. As far as the diarrhea that they may experience, Crohn's typically has non-bloody diarrhea, and ulcerative colitis almost exclusively has really bloody diarrhea. And so ulcerative colitis patients can get anemic or have low blood counts because they bleed so much with their diarrhea. And that creates the additional symptoms of anemia like fatigue, shortness of breath, racing heartbeat. Their shared symptoms are crampy abdominal pain, fevers, and then the ulcerative colitis can also have the symptoms outside the digestive system like the eyes or joints. So here's our pretty picture of ulcerative colitis on colonoscopy, and it's diagnosed via that and biopsy as well. Occasionally they can do something called a sigmoidoscopy instead of the colonoscopy, and that just means that the scope only goes up as far as the S-shaped portion of the colon. And they do this because that's the most commonly affected portion of the colon, so it saves you a more invasive scope of the entire colon. You can see in that picture they typically have just ulcers all over the place and red patchy areas from the bleeding. It's pretty inflamed. Treatment's roughly the same with steroids and medication that changes the immune system. The great thing about those medications in this particular instance is that they can promote the healing of the sores as well in the ulcerative colitis. The sores can be quite extensive, and they can actually affect the entire length of the colon sometimes. And if that becomes the case, then a lot of times they'll actually take out the entire colon just to prevent further flares. Okay, so two more types of colon diseases that we'll talk about. Ischemic colitis and infectious colitis. These do not fall under the same category of diseases as the Crohn's and colitis. They're both their own thing. But they're a little more pertinent to the geriatric and healthcare facility populations, so I definitely wanted to talk about these today. So we'll talk about ischemic colitis first. This just happens when blood flow is blocked to the intestines. I included the picture there because that portion of the colon where the transverse meets the descending colon is the most commonly affected area because it already has limited blood flow at baseline, and so when you block the blood flow off, it's definitely going to be affected. Symptoms of this: belly pain, particularly after eating, because the intestines require more blood to digest food, and if you can't get the blood to the intestines because of the blockage, then it's going to have a lot of problems. You can also have nausea, vomiting, bloody diarrhea, and weight loss, and that's usually just because you'll avoid eating just because of how bad the pain is. Some of the causes of this, it can be a gradual onset due to clogged arteries, kind of the same as heart disease, or it can be because of a sudden clot that blocks off blood flow. It's fairly common that AFib would be the root cause of that. AFib is just an irregular heart rhythm that can make you prone to develop clots, and those clots will travel to other areas of the body like the brain, or in this case the colon. So once again, our lovely picture. As you can see on colonoscopy, you'll see just kind of blackened tissue, and that just means that that part of the colon is dying because it's not getting good blood flow. You can also diagnose this sometimes via CT scan of the belly. It'll show intestines changing consistent with the poor blood flow. You can kind of see the death of the colon on that. And also sometimes they'll do something called angiography, and that's just where they inject dye into the arteries, and they can see if there's a particular place that's blocked off and if maybe some sort of intervention can be done to go in and pull the clot out. Treatments of this, if it's from a clot, then you'll need a blood thinner for it, and that'll require hospitalization. And then most commonly and most important would be surgery to remove the bad portion of the colon, because if you let this go, then you can end up with infections and rupture of the colon like we've kind of talked about. Hospitalization is typically required in all cases, at least for supportive care like fluids. Now, it's important to note in all four of the ones we've just talked about, the diverticulosis, the Crohn's colitis, and ulcerative colitis and ischemic colitis, all four of them can actually really benefit from lifestyle modifications. You can even prevent some of the flares. So weight loss, exercise, stopping smoking, and a low-fat, high-fiber diet are really important in preventing flares of these conditions. And then, of course, if your ischemic colitis is from AFib, then it's really important to adequately treat that and keep it under good control and be on long-term blood thinner to prevent further clots. And our last topic, we'll go over infectious colitis. So this is typically what we refer fondly to as stomach bugs. Most commonly caused by viruses. And that's usually person-to-person transfer. Can also be caused by bacteria from undercooked or poorly processed foods, or in particular traveling internationally to places that may not have as sanitary conditions as we do. These are really common in healthcare facilities and spread really rapidly just because of the proximity of the patients and healthcare workers going in and out of rooms. Symptoms with these viruses, you'll have diffuse abdominal pain, watery, non-bloody diarrhea typically, and they're often associated with vomiting as well, whereas bacteria may not have the vomiting, and the diarrhea can be bloody with the bacteria. There is one bacteria in particular that typically causes non-bloody diarrhea, and it's very important in a healthcare setting, and that is called C. diff. C. diff infections typically result from recent antibiotic use or contact with somebody else that's had C. diff. The diagnosis is typically just via stool studies, so they'll take a sample of your stool and test it for bacteria, and if you don't see any bacteria, then it's probably from a virus. Occasionally they'll do a colonoscopy, particularly if C. diff is the culprit and you're starting to have complications from it. So our colonoscopy picture here is a picture of what C. diff looks like in the colon. It just creates a film of bacteria in the colon. Treatment for these, you may or may not need antibiotics, just kind of depending on what the bacteria is and how bad the infection is. And of course, viruses never need antibiotics. But most of the time, these typically just run their course. C. diff, once again, is a big exception in this, so that it always needs antibiotics because it can have some really bad complications, like perforation or rupture of the colon, and then something called toxic megacolon, which is where the colon gets really distended and typically requires surgical removal of the colon. And C. diff can even lead to death as well if the infection's bad enough. So with all of these, prevention is the biggest thing that we need to worry about. Most of them you can fix with hand sanitizer or prevent transfer with hand sanitizer. C. diff, you actually have to wash your hands with soap and water. It's not affected by sanitizer. And if somebody ends up with a C. diff infection, they need to be isolated from the rest of the population, and healthcare workers need to wear appropriate gown and gloves when they go in and out of the room. As far as other bacteria, the biggest thing is just preventing the common causes, which is making sure to properly clean and cook your food. And that's all I've got. Yeah, so like Dr. Wright mentioned, we can take questions on that phone if you all want to call in. We're happy to answer to our best attempt. The number is 200-9259.
Excellent presentation, Dr. Williams. Thought you covered a somewhat difficult subject very well. Here's a question.
Hello.
It's wonderful to see things opening up at Butterfield Trail.
Yeah.
It lifts my spirits just to walk by the bistro
Okay.
and see it open.
Just a second to start talking. Okay.
Okay, so now we have the question.
Yeah. So our question is there anything else in the diet? Okay. Is there anything else in the dietary recommendations other than just high fiber, low fat that can prevent progression of diverticulosis into those complications? And I think that the answer these days is there used to be recommendations to keep out seeds and nuts and popcorn and that sort of thing, but I believe that it's changed and that's no longer a recommendation or a concern. The biggest thing is just making sure that you've got adequate fiber intake and low-fat diet. Do you have anything to add to that?
Yeah, I think it's a fiber for several reasons, but constipation makes this worse.
Mm-hmm.
So you want to keep bowels open and regular, if possible. It's those out pouches, the diverticula, are a result of chronic pressure upstream that
Are you there?
pushes between the muscles that wrap the colon, and the weak spots are where the pouches develop. So you want to avoid constipation. But I'm glad she pointed out that popcorn and seeds and things like that and nuts are not the no-no that they used to be thought of for diverticular disease. Got another one? I think we have another question.
Yeah, so similar question, if there were any specific foods that should be avoided in diverticulosis. And I think the answer these days is not really. Just as long as the fiber intake is adequate, you can pretty much eat what you want to eat these days.
Mm-hmm. Mm-hmm. You know, in this TV format that we've been using now throughout the COVID season, the one thing that I've shared with you before surprises me is that people are more reluctant to ask questions by phone than if we were in person, and I would have thought that that would be more inhibiting to stand up in a crowd and speak out, but I've learned otherwise. Another question?
This particular question was hoping that we could address celiac disease a little bit. The reason I didn't do that is because celiac typically doesn't affect the colon. It's usually a small bowel disease. But she specifically wanted to know about diagnosis and treatment of celiac disease. Diagnosis, there is some blood work that you can do to screen for it. And if that's elevated, they'll move on to a colonoscopy to biopsy the parts of the intestine that are typically affected by that. And then treatment is primarily just the gluten-free diet. We unfortunately don't have a magic pill to make celiac go away so you can eat what you want. You have to restrict gluten.
Fortunately, restaurants have over time accommodated more and more. It's used to be impossible to find gluten-free pizza, and now that's not a problem mostly. So that is a major symptomatic problem for folks of all ages. So. Yeah, I would just tag on to what Dr. Williams said about inflammatory bowel. That's the Crohn's disease and the ulcerative colitis. These are such horrific disorders, or potentially so, in folks if they have one of those diagnoses. The treatment has advanced in that, and she mentioned there are some medications that orchestrate a direction of antibodies that interfere with the inflammatory process. And so you see them, listen, you'll recognize these because you see them advertised on TV all the time. There's Humira, there are about 6 of them, but Humira, Remicade, Intivo, these are what we might call biologics. And so they work for autoimmune diseases like rheumatoid arthritis or Crohn's disease. And they have certainly been helpful in the management of Crohn's disease and in inflammatory bowel. So it's a really exciting area of advancement in medicine. Another question? Okay.
So that question was, can we explain what causes periodic loose bowels? So pretty much any of the ones we've talked about today can cause loose bowels. It can also be food sensitivities like gluten or lactose, or any kind of food allergies that you have can cause that. There's some other more complicated things. Some tumors and things like carcinoid or pheochromocytoma that can cause them. Those are some big fancy words, I know. But those are a lot more rare than what we've talked about today, and probably not behind most of your episodes of loose stools.
I think you did allude to IBS.
Yeah,
irritable.
IBS is probably your most common one, honestly. Just irritable bowel syndrome.
Yeah. Irritable bowel syndrome is a unique disorder that's very, very common, and there's nothing that's been found structurally wrong with the bowel, but the activity can be associated with any of a number of symptoms, from loose stools and diarrhea to constipation or alternating constipation and loose stools, and pain is often a characteristic thing, although that now the studies are showing subsets of IBS that some don't have pain at all, some predominate with diarrhea. They're learning more about it and how to categorize it and how better to treat it. But that's one of those things that you rule out everything else, and if you don't find anything, it's often irritable bowel. And it's manageable. There are medicines that will manage it, but it's not curable, and and there's no surgery there's nothing to be removed to relieve anything. So it can be a tough one too, so depending on how active it is. Any other category of bowel things? Those are great questions, and Dr. Williams gets a trophy. This is the most questions after a talk that we've had in this format of in-house TV presentation. So I hope that means that you're becoming a little more comfortable with calling in phone questions, because I think it always makes a presentation more effective if you're able to answer questions, because then you know you're giving information that's people are curious about or need to know. So we would always love to do that. Here comes another question. Look, she's set a fire on this.
Question?
This may be kind of an involved question.
Okay, so that question was, how would somebody know if they were having blood in the stool if it wasn't obvious blood, like bright red or maroon, if they were just having small amounts? There are some tests that can be run on the stool called an FOBT, and you would just take in a sample of your stool that's been rubbed on a little card, and they would run it and look for the blood. If you're having unexplained low blood counts and belly pain and that sort of thing, they may do a colonoscopy to look for blood in the colon. But really the easiest and quickest is that FOBT. That'll tell you if there's anything in there.
Yeah, the FOBT, which stands for fecal occult blood, fecal occult blood test, is really just checking for dissolved blood that you wouldn't see, and you can dissolve a lot of blood in the colon, or quite a bit. A trickle of bleeding, from a significant source, can go unnoticed for a long time. By the time it's turning your stool black, it's because you're really bleeding pretty actively. Mm-hmm. So, that's an important question, because just not seeing visible gross blood doesn't mean there's no significant blood in the stool. Well, that's great. That's more questions than I expected, based on experience, and delighted. I hope we'll make that a habit. We'll try to encourage it. Before we close, we'll be closing a little early then, but before we sign off, I just want to tell all of you here at Butterfield Trail, because I think it's a credit to all of you, to the staff, and then to everyone who lives here. The participation in the vaccination, I think, has just been magnificent. And I'm not just saying that to flatter you. I'm not above flattery, but on the other hand, I want to tell you, I don't know of any place that's gotten over 99% participation in vaccination. You all know, and you may not, living here, have somebody next door that is against vaccination, but there are a lot of people who are, if not against it, they're at least what's now being called vaccine hesitant. I'm glad folks at Butterfield Trail, I'm sure there's been some hesitancy, but we've all needed to do for ourselves and for the community, do the soul searching and the wise decision making that has allowed you to go ahead and get vaccinated. I think this is such a huge part of getting past this pandemic, and I've been inspired by the words of so many people who live here, so many of our patients especially, saying, you've lived through a lot of things and you know that this will not last forever, but on the other hand, it's taken a toll on us all. And what we can do for our own community right here at Butterfield and for the broader community, includes vaccination, and I'm just so proud of everyone for doing that. And then, I don't think I mentioned this before, but I'll tell you what someone told me back in the first months of the pandemic. One of our great patients here came in, and I said, well, how are you holding up? And I've tried to make it a practice of asking everyone, how are you coping with this unnatural time? And he said, well, it's tough. It's really tough. But he said, you know what? From what I gather, there's not a person on the planet who isn't threatened potentially by this. So it's not just us. And that's exactly right. That's by definition what a pandemic is. And if we didn't know what a pandemic was before, we sure know now, don't we? So again, thank you and congratulations for that participation. There's no place that's gotten more sign up for vaccinations than Butterfield Trail, and I tell people that all the time. So thanks for doing that. And I think that's right now one of the most patriotic things you can do for your country is get vaccinated. And now we're on to the next tier and tiers, and we're hoping by the end of May we've got vaccine for everybody who's willing to take it. And maybe in that time we've talked some more people into not being vaccine hesitant or resistant, but going ahead and getting it, where we can move past this at some time in the foreseeable future. So again, thank you, and thank you, Dr. Williams, for a great presentation. We're going to be signing off early. Nathan?